some treatment before, or maybe half of patients I see did not receive any treatment, or did not have investigation for this problem.
Okay, yeah, that's very helpful. And then, so would you differentiate between the patients where you can't identify the underlying disease, and versus refractory patients, or do you see idiopathic chronic cough, or do you mostly see refractory chronic cough as a persistent chronic cough?
Before saying that the chronic cough is idiopathic, my opinion is you have to perform some exams, or many exams. And when you don't find anything, maybe you can see that the chronic cough is idiopathic. But so when I see the patient, I perform some investigation to try to understand the cause of the chronic cough. So I try investigation, or sometimes I give treatment without investigation. But most of the time, I perform, for example, a functional test, a respiratory functional test. Sometimes I ask him to go to the gastroenterologist. It depends of the patient I have in front of me.
Yeah. Okay. And so, roughly, what percentage of your patients then have, or would you identify with true idiopathic chronic cough? Can you give a rough estimate? Is it something you see really rare, or do you see that actually fairly common because you see these highly selected patients already?
If I don't find anything in patient, maybe it's maybe 10 or to 20% of my patient, because usually I try to see if they take medication that can create a chronic cough, or I see if they have sinusitis, or asthma, of course, reflux, for example. And if I find nothing, I give them some medication. So maybe anti-allergic, usually antihistaminic, or inhaled steroids, to try to see if it has an effect on the chronic cough. Maybe, so I have a strategy for that. Maybe another doctor will not have exactly the same strategy. So you can give first antihistaminics or first inhaled steroid. You have to choose what you want to treat, but sometimes you give what you want, and the cough is persistent.
Still persistent, yeah. And do you see a difference between those patients where you can identify the cause, like GERD or nasal drip, and even if the cause is treated, they still continue coughing? So this more refractory chronic cough? Or are these patient types actually really similar to the ones you've just described?
The symptom is the same. There is no difference. It's the cough. The patient, you can explain what you want. He tell you that he have cough. So the difference, if you find nothing, you have, of course, you can have a reflex or hypersensitivity cough. But if you make a name of the cough on the cough, even if it's idiopathic, you explain to the patient that you didn't find anything, no reflux, nothing special, no asthma, no medication that could create the cough. So if you say to the patient that you perform many exams and you didn't find anything, and so you explain to him that he has a idiopathic or hypersensitivity cough, maybe he's more, how could I say, he's more confident, and he's happy with that, because you make some exams and you try to find the cause. For the moment, maybe